Good afternoon, everyone. Welcome to the MDS series. This is the second in a four-part series with Jennifer LaBay. Today's presentation will be taking a shot at the influenza pneumococcal vaccination quality measures, as well as for a little cherry on top, Jennifer will be talking about the ADL section, section G regarding ADLs. So if I could take a minute and introduce your speaker to you, Jennifer LaBay. Jennifer is a registered nurse. She's certified with RAC-MT, RAC-MTA, and CRC. And she's the MDS policy consultant for Triad Healthcare in Providence, Rhode Island. She also is an AAPACN training partner and AANAC master teacher as an independent contractor with JLB MDS Consulting in Pawtucket, Rhode Island. She has been involved in the RAI process since 1997 and has been in the long-term care industry since 1991, serving in a variety of capacities, including CNA, charge nurse, MDS coordinator, and regional corporate clinical reimbursement specialist. Jennifer has been a master teacher for AANAC's RAC-CT program since July of 2011, AANAC's Retired Medicare University program since October of 2012, and AANAC's New Advanced RAC-CTA since 2019. Jennifer is a certified risk coder through the American Academy of Professional Coders. Jennifer has considerable expertise in the MDS, RAI, PPS, ICD-10, including the clinical and financial aspects. She has a knack for making her seminars an enjoyable learning experience and readily makes herself available to all attendees of her programs for any follow-up questions that may arise long after the seminar is complete. If I could just take a minute and remind everybody to please mute your microphones unless you are speaking. And Jennifer, the floor is yours.
Well, thank you, Jill, and thank you to Mountain Pacific Quality Health for having me again. I've enjoyed bringing some information to you. I'm seeing in the chat that people can't hear. I don't know if it's just that one person or if everybody's having an issue. Jill, you can hear me okay, yes?
Yes,
okay,
I can hear you.
Okay, so yeah, you may want to just respond to that person in the chat. It might just be them. Maybe their volume is down or something. Thank you for the feedback in the chat, everybody. And I believe I have my screen shared. So why don't we get started? So good morning and afternoon, wherever you may be. I'm halfway into the afternoon out here on the East Coast. So today we're going to talk a little bit about the flu and pneumococcal vaccinations. It's only a couple of sections, so that's why we kind of, if we have some time, tack on some information about section G at the end, because there always seems to be lingering questions about section G. But let's first talk about our flu and pneumonia vaccine coding. Mountain Pacific Quality Health has put out a very nice tip sheet, and there's some really great information on there. If you have that tip sheet, some of this information is right from that tip sheet. If not, I'm sure the folks at Mountain Pacific Quality Health will be happy to send that along to you. So we want to make sure that we have a very strong process in place to make sure that the vaccination history is obtained for all new admissions. This information shouldn't be overlooked. It shouldn't just be like, oh, well, you know, it's not really important. We don't really need it. And then it gets forgotten about. We really need to make sure that we're taking this into account. There are 16 quality measures that are associated with the flu and pneumococcal vaccination. So this isn't something piddly. We definitely need to make sure that we're getting this information. It's important for the resident to make sure that they haven't slipped through the cracks. If they you know, maybe they didn't want to go out of the house because of everything that's been going on, you know, in their community, depending on what, you know, the COVID rates are. Have they been out to get that flu vaccination? Maybe they didn't go down to the local pharmacy like they usually do, or they didn't get to their doctor's office and it wasn't available. So we really want to make sure they don't slip through the cracks, they get vaccinated appropriately, because they don't need that on top of anything else that they might be exposed to. And we want to make sure that we're not giving them something they don't need. So if we have the information, we're not going to be giving them additional, you know, a vaccine that they don't need because they've already gotten it and we just didn't get that correct documentation in place. So we want to make sure that we're requesting the flu vaccine and the pneumococcal administration dates, the type of vaccine that was given, when you're getting that person in from whatever transferring facility, whether it's a hospital, another nursing facility, an assisted living, if they're coming in from home. If you're not able to get it from that, there are, I mean, you certainly can ask the resident. I mean, they may have a good idea of when they got that flu vaccine, or their family members. Reach out to their community physician. They should have some records on that, hopefully, as well. You want to create some sort of way to have a checklist to make sure that this is, you know, being checked. A lot of people do have that on their, you know, nursing admission, observation, or assessment, whatever you call it in your organization. But maybe also have, because a lot of, oh, well, I don't have that information, so we're just going to kind of skim through it. There needs to be a check, a double check or triple check to make sure that we have this information in place. Work with your discharge planners and your care coordinators at the hospitals and whatever discharging facility to make sure that you make that a high priority. We want to make sure that we have that information so we can make sure that if they aren't up to date, that we can get them up to date as soon as they get in the building, to make sure that we're protecting our folks that are coming in. You want to follow the administration guidelines, of course, any contraindications and precautions, and be mindful of other vaccines. There are some requirements if they've recently received a vaccine and the COVID-19 vaccine surrounding that. You have to wait 14 days. So we need to make sure that we have all of that information, not just about the flu and pneumonia. Certainly we want to know about their COVID vaccination status as well. And then you want to confirm, like I said, with the resident, with the family, make sure that you have that information. Not only is this a requirement for MDS coding and then a quality measure trigger, but it's also a regulatory requirement under infection control. It is the responsibility of the facility to develop and follow policies and procedures related to the flu and pneumonia vaccine, that we are offering it, that we have the documentation of it. If it wasn't given, all of those information is documented as to why. Something I recently stumbled onto, oh, I see an update. We no longer need to space the vaccines with the COVID. Thank you for that update. I'm not as up to date with all of that information, so I appreciate the feedback in the chat. Thank you very much. As I said, something that I have recently come into knowledge, which I wasn't aware of. I'm not an infection preventionist, so that isn't really my jam. You know, I can tell you how to code it on the MDS, but I never needed to follow up with it in the facilities. But apparently there are these state vaccination registries. I was teaching a class a few months ago, and one of my students said, hey, we've got this registry that you can, you know, get a login into and find out the vaccination status of folks if that information is in there. So these are the 4 different state vaccination registries for Wyoming, Montana, Hawaii, and Alaska. So check those out and see what you can do to get logged in and have that information hopefully at your fingertips about your residents. So this could be part of your process strategy to make sure that we are checking everything out. And oh yes, I see Mountain Pacific is putting those links in the chat for us. Thank you. So let's first talk about the flu vaccination coding at 00250 on the MDS. So 00250 is asking if the facility gave the vaccination the date of the jab, and if the facility did not give the injection, the reason why. So it's important, these are straight out of the RAI manual. We need to review the resident's medical record, the hospital transfer records, talk to the family members, find out what we can to make sure that they are up to date with their current flu season vaccination. If we don't see that in the medical record, we go to the resident. If we don't get it from the resident, we go to the family member or their responsible party, or even their primary care physician, either in-house, or if you know who their primary care physician is in the community, reach out to them, because a lot of times they're gonna have those records. If the flu vaccine status cannot be determined, the instruction is to administer the flu vaccine according to the standards of clinical practice. Ideally, all of this follow-up should be done on admission if they're being admitted during the flu season, and it should be completed prior to the ARD of that admission assessment. So some reasons why the flu vaccine is not received. So 0250 is asking, did we give that injection? And then the date of that injection, we should never be dashing that out. We should know if we gave somebody an injection or not. If we did not give the injection, then we need to choose a reason. Code 1, if the resident wasn't in the facility during this year's flu vaccination season. If they weren't in your building during flu season, you don't need to give that. So we would code that they weren't here. Perfectly appropriate. We're currently not in flu season at the moment. We're into June. If they've received outside of the facility. So for the current flu season, if they have received it in another entity, if they have gotten at the local pharmacy, at a flu clinic, at their doctor's office, you can indicate that. That is another one of those items that's going to trigger on the quality measure. So I see a question in the chat. Is it accurate to continue offering the flu vaccine past the typical flu season if the product is still available and not expired? Wow, that is a great question. The flu season is going to vary depending on your location. I'm in New England. We're kind of always in a rolling flu season. So as I said, I'm not an infection preventionist, so I don't want to give the wrong information related to that. But in my area, we're kind of always in a rolling season. So if it's not up to date, we give it. But it may vary depending on your location. So you would want to check what that specific mandate is for flu season in your locale. But that's a great question. Code 3 is not eligible. So if there's a medical contraindication, if for whatever reason they can't receive it, they've had a reaction in the past, they are allergic to a component, if they've had some moderate to severe illness with or without fever, you can give that after the acute illness. If they have a history of, I can never pronounce it, Guillain-Barré, I never say it right, syndrome within 6 weeks after previous influenza vaccination. And prior to my update on that I received in the chat about the timeframes around the COVID, if you were in that time frame when it was still a concern to not be giving the vaccines around that, that would also be considered a medical contraindication until you pass that time frame. So I apologize, I'm not up on my COVID vaccine timeframes. Offered and declined. So we have offered the flu vaccine to the resident and they said, no, I'm good. I don't want it. Thank you very much. Or not offered. Now, a lot of people are afraid to code this. And I get it. I understand it's going to look bad that, why didn't we offer it? But depending on when your ARD is of your assessment that you're completing and when you've done your follow-up, to find out, did they get it? Have I heard back from the physician? Have I heard back from the pharmacy? Have I gotten into that registry? You may not have the information and you may not have offered it yet. And that's perfectly okay. you can code that, because with this quality measure, it only captures once. So if you don't capture it on this assessment, you don't have the right data, the next assessment that you complete, maybe we can say we've offered it and declined. They received it somewhere else and we have the correct data. So it doesn't have to be accurate every single quarter. It just needs to be accurate as of your ARD with the information that you have. I see another question in the chat. For the pneumonia and flu vaccine, consented, but for some reason vaccine was not given, like the availability of the vaccine. What is the proper code? I would code not offered at that point because you haven't offered it. And then you can write a note. I'm a big, huge fan of MDS notes. A lot of the softwares have a spot to write that. That's how I would personally code it. Some people may say that's none of the above because we've offered it, but they didn't get it. And you could code that as well. And again, I'm a big fan. I want to tell the story of why I coded the way I did if it's not very clear in the rest of the medical record. So you can write an MDS note to explain that. Great question. Code 6, inability to obtain the flu vaccine due to a declared shortage. It has to be just that, not that you haven't received it from your pharmacy or Department of Health yet, but that there is an actual declared shortage in your area. You should and would know about that. Again, you would want to document in an MDS note to explain. And then none of the above. If you feel that none of those reasons fit why the influenza vaccine was not administered, and you're also going to code this if the answer is unknown. So that code 9 does give you that option. So when we're looking at the calculation for quality measures, it's important to understand what is being calculated and when. There are some special rules for the flu vaccine quality measure. And this is out of the QM manual. The flu vaccine measure calculates, as I said, only once per 12-month influenza season. So it begins July 1st of a given year, ends June 30th of a subsequent year. So this June 30th is the end of this 12-month period going back to July 1st of 2020. And then starting July 1st of 2021, then that's going to go through June 30th of 2022 to calculate for that quality measure. So for these measures, the target period for the flu season for MDS purposes and calculation of the quality measure purposes is October 1st through March 31st. So that means the end of the episode date is going to be March 31st. For an episode that is ongoing at the end of the flu season, and that March 31st would be used as the end date when you're computing that cumulative days in the facility to determine if you're calculating a short stay quality measure, the 100 days or less, or a long stay quality measure, 101 days or more. So this target period of October 1st through March 31st is different than the selection period, which begins on October 1st and ends June 30th. The flu season itself for MDS calculation purposes is October 1st through March 31st. Sidebar, it may be different in your area. Generally, the rule of thumb is if you start to see advertisements at the local CVS or pharmacy that says get your flu vaccine here and it's September or August, then that's actually flu season for your area. But when it comes to calculation for the quality measure, it's not going to count until you hit that October 1st date through March 31st. That's what the calculation is going to be. So it's important to understand if this person is in your facility March 31st, between October 1st and March 31st, then we have to calculate that because they're considered in being in your facility during that flu season. There may not be an assessment. So if they come in on March 31st, you're not necessarily going to have an ARD within the flu season, but they were here within the flu season. So that's why the selection period goes all the way up to June 30th. So that way you can have an assessment somewhere in that time period that is going to calculate and capture their flu vaccination status because they were in your building during that flu season. So as I said, that selection period is different to allow for, maybe we haven't picked it up on an MDS yet. And now we finally have given that flu vaccine on March 31st, but they're not due for another assessment. Maybe their ARD was March 29th. They're not due for an assessment until the end of June. So now that assessment in the end of June will pick up that flu vaccine that was given March 31st. So it kind of allows for that catch-all, but it's not talking about any of the injections that may have been given between April 1st and June 30th. Those aren't being counted for that particular quality measure for that flu season. So the logic for calculating the quality measures, like we talked about in the last slide, the selection period uses that June 30th end date to ensure that we haven't missed anybody between that end of that flu season, if they hadn't had an MDS yet, if they're late to the party and haven't gotten that flu vaccine, or they're a March admit and we don't have that status known yet, we can pick that up on the next assessment, the next quarter. We are going to be then calculating that cumulative days in the facility as of March 31st. So if the resident was just admitted on March 31st, they're going to be calculating a short stay quality measure. If they were admitted and had 101 days as of March 31st, then they're going to calculate for the long stay quality measure. The measures are the same. It's just long stay versus short stay, whether they've been in the facility 100 days or less, or 101 days or more. It's all about determining when they were admitted into your facility. So if they were admitted into your facility during that October 1st through March 31st period, that's what we're going to be looking at to make sure that we have calculated that information on that subsequent MDS. You want to make sure that you've truly captured everything for that time period. So that gives you a 3-month catch-up period, if you will. But the injections would have had to have been given during that flu season. We do have an exclusion for this quality measure. There's an age exclusion, 179 days or younger. The child must be at least 6 months old to receive this. So if you're in a pediatric facility, any kids under 6 months would be excluded from the quality measure calculation. So first, the quality measure looks at all of these items. So we have 8 total quality measures for our flu vaccine, 4 short stay, 4 long stay. The first one, they're the same. Like I said, the 4 long stay and the 4 short stay are the same, other than the cumulative days that the resident's in the facility. So the first quality measure looks at all of the items. The resident received the flu vaccine during the most recent influenza season, either in the facility or outside of the facility. Then it breaks it down. The resident was offered and declined the flu vaccine, or the resident was ineligible. So we've got a few things that we're looking at here. Did they receive it either here or outside of the facility? Did we offer it and they declined, or were they ineligible to receive it? So we've got 4 different quality measures for that flu vaccine, for short stay, for long stay. Some tips, as I said, O0 to 50A should never be dashed. We should know if we gave a resident an injection in our facility or not. So you want to use caution when using parts of the medical record that may auto-populate your MDS depending on your software. I'm not a huge fan of auto-populating software because if it's not entered correctly in that other part of the software, or the folks that are entering that information, if they don't know MDS rules and it carries over, it may not be carrying over correctly based on MDS rules. So that's my soapbox. Grain of salt when you're auto importing things from other parts of the medical record. You always want to check somewhere else, make sure that you have all that information. If you're not able to give the flu vaccine due to the proximity of the COVID vaccine, if that was an issue previously, apparently that's not, and I apologize for my lack of update on that. But as I said, that would be the medically ineligible at that point until they are able to receive. For the long-term folks, you always want to enter the date the facility administered the flu vaccine and leave that there until the next flu clinic or when they get their next injection. Even if it's from the previous flu season, just carry it over. It's going to carry over for you. And no matter what you do, you want to have a strong process in place. Somebody needs to be in charge of checking, and it doesn't necessarily have to be the admitting nurse, because they're trying to get everything done and validate the meds and talk to the doc and get this stuff entered and you know, do all of that stuff that they need to do. There needs to be some follow-up the next day, somewhere, somehow, somebody should be checking to make sure that we have that information, that we have the right information. They've received it, they haven't received it, and what are we going to do if we've exhausted all of our avenues, and should we be giving it now? This is something that the MDS coordinator or whoever's coding this section of the MDS needs to be aware of the process. We need to make sure that we have that information and that it's not, we're not just relying on what's in the computer system. You want to audit O250A for any indication that the resident did not receive the vaccination in your facility. So be prepared, maybe start to do some audits in June to make sure everybody's stuff is there. So when the quality measure gets calculated for that flu season, you've got the right information. The vaccine wasn't offered. Why wasn't it offered? Can we offer it now? Is there a better a reason for the vaccination not being administered? Inability to obtain. Why were we unable to obtain? Was there a declared shortage? Is that shortage resolved? Should we try again? Or none of the above. As I said, this should be rare. In most cases, the reason the flu vaccine was not administered meets the other reasons. Utilize your software. A lot of times they can create some sort of report to tell you if there's some coding. So see what your software can do for you. Sometimes they can do that. Remember, if they're not in the facility during this year's flu season, that means A1600 if it's a new admission from April 1st to September 30th. And their ARD is between April 1st and September 30th for a new admission, or otherwise they'd be in your facility, either prior to in the prior flu season or going into the current season. If the resident is in your facility October 1st through March 31st, they were in your facility, even if it's for a day, and even if the ARD was not during the flu season. So some steps for completion for O300A, now going into the pneumococcal. Again, similar to the flu, we need to review the medical record to see if they are up to date with their pneumococcal vaccine. If the vaccine status is unknown, then we're going to ask the resident, ask their responsible party, find out from their physician, maybe go to that state registry. If we're still not able to get that information, then we are going to administer. You want to see, do they have any allergies or history of severe allergic reaction? Obviously, we wouldn't be administering it. If they have moderate to severe acute illness, the vaccine should be administered after that acute illness. If the resident has a minor illness, check with the resident's physician before administering the vaccine. So what this question is asking is not, did we give the injection? This question is asking, is it up to date? So that's a completely different thing. They may have received it years ago, and based on their age at the time and how long ago they received it, they may be up to date. It varies depending on their age, depending on what vaccine they received. Sometimes you need 1 dose, 2 doses. CDC does have a nice grid. If you do a search for the adult vaccination schedule on in CDC, it's a really nice grid. It gives you everything and shows different age ranges and situations and what the time frames are for those. So our coding instructions for the pneumococcal, if they are not up to date, code 1 if they're not eligible. They're not eligible due to medical contraindication. They have a history of allergy or other issues associated with that. We've offered it to them and they have declined, would be a code 2, or not offered. Resident or responsible party was not offered the pneumococcal vaccine. And if we haven't offered it, we haven't offered it. And that's what it is going to be for that assessment. The next assessment, maybe we, we'll find out otherwise. So this is why it's so important to make sure that we're assessing this information right on admit, because we don't want to be caught in a situation where we're saying not offered, because that doesn't sound very good either. We want to make sure that we have all that information. But if that truly is the case, that is what you need to code. So similar to the flu vaccine, we have 8 total quality measures for long stay, for short stay. I just see something in the chat. So question, does this mean that the resident needs to have both of the vaccines, the 13 and the 23? No, it's up to the physician and that schedule. Again, I am not an infection preventionist, so that is not my area of expertise. Like I said, I can tell you how to code it on the MDS. I always have to go back to that grid and refer. So if they received one, meaning sometimes you need 2 doses, and I don't know of which one, so please don't quote me, but say that the 13 needs 2 doses, and they have to be a year apart. If they've only had 1 dose and it hasn't been the year yet, then they're considered to be up to date. I kind of think of it, I have a 6-year-old, so I was all familiar with the vaccine schedule when she was a baby. She wasn't due for her next one until her next wellness visit, so she was up to date at that point. So I always kind of think of it that way, but it doesn't mean they have to have both the 13 and the 23, but sometimes there's doses that are split up for that particular vaccine. So always want to check with your physician and make sure that whatever they have received, you have documentation of, and then utilize that schedule from the CDC website. So our 8 quality measures, first item we're looking at, resident meeting any of the following criteria on the selected target assessment. So this isn't capturing once a year, this is looking at the target assessment. So this is looking at every time an assessment is completed with this question on it, it is going to calculate this quality measure. Pneumococcal vaccine status is up to date, or they were offered and declined, or they were ineligible due to the medical contraindication. And then again, it's broken down separately into each one of those. So the first one calculates all of that, and then individually you have a quality measure just for the vaccine up to date, a quality measure just for being offered and declined, and a quality measure just for being ineligible. So it multiplies 16 different quality measures between these 2 vaccinations. Up to date, as I said, depending on what those recommendations are on the CDC schedule. If they are not due for their next shot yet, they are considered to be up to date. Vaccine not offered, again, should be rare as a reason why the pneumococcal vaccine is not up to date. It is possible, like I said, depending on how soon your ARD is upon admission, that maybe you haven't done that research yet. You haven't gotten that information. You don't know if it needs to be offered. You don't know what the status is. We're waiting for a phone call. We're waiting for medical records, whatever it is. So for this assessment, maybe it is vaccine not offered. By the time the next assessment comes, maybe we were able to get that information, and now we can say, we've either given it or it's up to date or whatever the status is. You want to review your MDS coding and make sure that you're utilizing the correction process. If you have information that maybe didn't make it onto the MDS, maybe someone else is in charge of following up on immunizations, and maybe they keep their records somewhere else in their office, in a binder, in a log, in a somewhere, and maybe it hasn't made it into the medical record yet. Maybe you have somebody covering for MDS, or you have a new person in MDS and they don't know quite where to go outside of maybe that electronic record or the chart on the unit to get that information. So we want to make sure that whoever's the keeper of that information, that information is out there for the MDS coordinator or whoever's coding this section to use, and capture that appropriately on the MDS. And again, the proximity of the COVID vaccines, if that was an issue prior, that would be medically contraindicated. So I see a question in the chat. If the resident refused or declined the vaccination at this AR period, how often do we need to reoffer it? Well, if they refused, I mean, honestly, I don't know if there's a particular regulation in place as far as to how often we should should offer that. That is a question I would actually have to look up myself because I'm not privy to that. I don't know if any of our other folks have more information on. Let me just jot a note. Declined. How often? But if they've offered it and they said no, I mean, they have the right to refuse. I don't think they're going to want to be harped on. But I don't know if there's any official regulation on that. So before we hop into our side dish of a completely different subject matter, any other further questions associated with the flu or pneumococcal vaccine? Okay, I see in the chat. Yes, so the CDC in the chat, we've got a link from the CDC to determine which vaccine they should get, the 23 or 13. Thank you for that. CDC's got a lot of great references. Yeah, they're busy with other stuff, but they still have a lot of great references related to the old standards with vaccinations and schedules. So not hearing any further questions at the moment. If you think of any, feel free to hop in. I'm gonna switch gears a little bit just because I knew we weren't gonna be able to quite fill the full hour with the flu or pneumococcal vaccine, just because it's, two small sections of the MDS, but they pack a punch. Like I said, 16 different quality measures are calculated off of these two items. So it's not something that we should just be poo-pooing. There really needs to be an effort put into it and an importance put on that, and somebody following up, whether it's your infection preventionist or whoever it may be. Somebody has to take some ownership on that and make sure that it gets documented properly in your medical records so that it carries over to the MDS correctly, however you do that. Paper, electronic, automatic, press a button and it updates from your software, trust but verify on that, but just make sure that information is there. Did somebody have a question?
No, I do not oversmoke. And over it, even you don't code it during your admission, but it's the ideal to do that it on admission. But for example, you cannot do anything about it. So still
If we could just remind everybody to please mute.
Well, I think she's asking a question, but I think she's just choppy. I'm having a real hard time hearing you.
Okay.
Yeah, I think your whoever's asking the question, your audio is super choppy. And
I have to understand is the
timing,
dates,
the
yeah,
timing of quality
measure.
So for the timing for the quality measure, so for the flu, it's once a year with your period of July 1st. So it would be for the one that's coming up, it's going to be July 1st of 2020 through June 30th of 2021. And that's a once a year calculation. Once that's calculated, it's not going to get calculated again until next year. For the pneumococcal, that's every time you do an MDS, that trigger, that's that target assessment is going to go by whatever's coded on that MDS. So every time you do a new MDS, it will trigger the quality measure based on that target assessment. So the flu vaccine, you have a year. Pneumococcal is as you do each MDS, whatever the most recent MDS says, that will calculate the quality measure. Hopefully that answered your question, because it was choppy. I apologize. So I'm not going to, I could talk about section G forever. I realize there's not much of a connection between the flu and pneumonia vaccination and coding ADLs, but we were trying to think of, well, where are some hot button issues that we get a lot of questions on that we could maybe throw a little sauce onto this presentation. They both affect quality measures, the pneumococcal and flu and the ADLs. So that's our connection. They trigger quality measures. So like I said, we've received lots of questions. So we're just going to kind of do a brief overview and maybe throw some documentation tips and strategies in there. Obviously, the importance of ADL accuracy, Section G has a great deal of potential for inaccuracy due to misunderstanding of definitions of the ADLs themselves, as well as the definitions of self-performance levels. So it's very important that all of the team members, not just the MDS coordinator, not just whoever's doing Section G, but all of the team members who might be doing any documentation related to Section G and ADLs, understand what needs to be assessed. And then obviously you throw Section GG in there, and that throws an even bigger monkey wrench in it, because it's completely different definitions and you know, how you code and your time periods and all of that fun. So we still have Section G in play. It's important for care planning, to make sure that we are giving the right amount of care for quality and survey. We've got lots of quality measures that calculate out of Section G, and determining, do they even need to be here? Like, if they're independent with everything, why are they in our facility? It's super important to make sure that this information is accurate. Section G was supposed to go away with all of the changes that were going to occur last October. COVID prevented the REI manual updates, but it's not COVID that prevented Section G. That actually was decided to not remove from the REI before the decision to not update the REI manual, because there was too many moving parts that Section G still has a hold on. Quality measures, you know, actual triggering of quality measures, and actual covariates for other quality measures were part of that as well. So that's why we are still going to have Section G in play until they can figure out the calculation of these quality measures and the covariates from the other items that are affecting other quality measures, how they can do that without using Section G. It's a good thing for the states that were still using the legacy payment, the RUGS program, because then we're still calculating it off of an OBRA assessment. We don't have to worry about the optional state assessments, all of that fun. So it was good in that a little bit. I try to look at the silver lining of still having Section G in play, but it is still here. So the quality measures that are directly affected by Section G, you can see here on your screen, the late loss ADL decline, which is officially the residents who need for help in ADLs has increased. I always call that the ADL decline one, late loss ADL decline. Bed mobility, transfer, toilet use, eating. Percent of residents whose ability to move independently worsened. That is the short name of the locomotion on unit has declined from the previous assessment. Percent of residents who made improvement in function is looking at transfer, self-performance, locomotion on unit, self-performance, and walk-in corridor self-performance. So there's still a lot of continued use of Section G. These are our ADL categories. Those with the asterisk are our late loss ADLs, as we know. So we want to make sure, from a documentation standpoint, you want to make sure that your CNAs, if you're using CNA documentation, and if you're using it in MDS terminology, that the CNAs understand what it means. I'm personally not a fan of documenting, CNAs documenting in MDS terminology, because it took me 2 years as an RN doing MDSs full time before I really understood the difference between extensive assist and limited assist. And now we're going to ask the CNAs to do that. So I'm not a huge fan, but I know that, you know, 90% of facilities with EHRs and point of care kiosks, they all jive. So you need to make sure that you're using that as a starting point. A, the CNAs understand the definitions, and B, that they're documenting appropriately. So you can use all parts of the medical record. It's not just the CNA documentation, nursing assessments, therapy notes. The therapy documentation would be any functional ADLs, not just stuff they're doing for practice, but they functionally transferred them and walked them down to the therapy room, or they toileted them, or they did their EDLs. But we can use all parts of the medical record. We need to make sure we're all looking at the same definitions. The nurses on the unit may not be trained in the definitions that's in the REI manual. The therapy department may not have the same breakdown of what is min, mod, and max assist. Some therapists use min, mod, min, mod, and max assist to indicate a degree of extensive assist and weight-bearing assistance. Other therapy departments utilize min, mod, and max, similar to how section GG is coded, more than half the effort, less than half the effort. So you really have to understand what everybody understands. So when you're just looking in the medical record and it says min assist, you can't presume that they mean there's weight bearing associated with that. It could mean something else to your therapy department. It's not standardized, I found, in talking with several therapists over the years. So you really have to make sure you understand what your therapy team means by their documentation. I like to use the CNA documentation as a starting point only. You cannot get away with doing section G, honestly, without doing some talking with the staff. I mean, certainly if you know the resident well and you've talked to the staff and the documentation supports what really has occurred, but if it's all over the place, if you only have a couple of days worth of documentation, a couple of shifts worth of documentation, you have to interview the staff and find out what actually happened to the resident. Whoever is coding section G on the MDS is signing that in section Z400 to say that to the best of their knowledge, this information is accurate and reflects what actually went on during this observation period. It's not saying this is what the CNA is documented and everybody has to match with that. No, we have to interview the staff, ask probing questions of the staff. Don't ask the staff, well, were they limited assist or extensive assist? If we already know they don't know the difference, or there's a concern that they don't know the difference, we need to ask them the questions. Did you lift their leg? How many times did you do that? Did you have to boost them? Did you have to use your muscles? How many bites did you give them? How many meals did you have to feed them? Did they help at all? There's a lot of nice examples in the REI manual. Like I said, I could talk about section G, excuse me, for a while. But the information really it has to be reflective of what actually happened, not just what the CNAs may have gotten into the point of care kiosk that carries over into your electronic health record, but that you really have dug down. Like, to be honest, you could actually code the MDS on day one of the observation period. If they're an extensive assist 3 times for bed mobility on day one, you can't get any more dependent than that. We're not going to go too deep into the rules of, we got the rules of 3 and all of that, but you really have to assess and talk to the staff and use those MDS notes, like I said, to really support the care that actually happened during that observation period. I see a question in the chat. Oh, it's just from Mount Pacific. So take a peek in the chat, just make sure that you are following up for attendance purposes. When you're reviewing the records, interviewing the staff, observing, make sure that you're being specific in evaluating each component of the ADL. So the ADLs, we've got our bed mobility transfer, toilet use, locomotion, all of those different things, but there's different components. So for bed mobility, for example, it's not just rolling side to side. It's once their butt is on the mattress, anything that happens at that point. So lifting their legs up, putting their head down on the pillow, after transfer, prepping them for transfer, lifting their head up off the pillow and moving their legs down, rolling them side to side during incontinent care is bed mobility. So there's different components. If you just have to lift their leg onto the bed, and then once they're in the bed, they can do flips by themselves, you still had to lift their leg onto the bed. That's bed mobility. That's weight-bearing assistance. That's extensive assist. So you really need to make sure, as the MDS coder, that you have a good understanding of all the definitions, because it's actually pretty easy to code somebody as an extensive assist, because there's 2 definitions. Either you provided all of the care except for 1 or 2 times, or you lifted one tiny body part 3 times. It's a huge, huge range. And it's super important to make sure that we get that documentation coded accurately, but to the highest level of dependence that can be coded on the earliest assessment as possible. Because with these quality measures, it can be just a tiny change in that quality measure that's going to trigger you. And if you really looked at the definition, they really actually met that definition of an extensive assist much earlier, but we didn't have we didn't have that documentation to support it. We didn't do that investigation to support that. It's super, super easy. There's a huge range of ability within extensive assist. So like I said, we're not going to go through all of these slides, but these are our different definitions of bed mobility. Like I said, anything that happens when the butt is on the mattress is bed mobility. Transfer, bed to chair, chair to chair, chair to bed. What we don't count here is bathing, shower, toilet. Those transfers are coded either under toilet use or the bathing and G120. Transfer also includes a transfer to the floor. So if they got up and fell, that isn't an unsuccessful transfer, but it is a transfer. Picking them up off the floor is a transfer. So we want to be considerate of that as well when we're either looking at the medical record or interviewing the staff. Walking in room, walking in corridor, how they actually ambulate, not pedaling with their feet. Still hear some folks say, well, for them, walking is, pedaling in the wheelchair. No. Locomotion on and off the unit. I just want to take a quick minute with this one. Locomotion on unit, so that's going to trigger your percent of residents whose ability to move independently has worsened. This is very easy to trigger. If you go from an independent to a supervision on the next assessment, you're going to trigger this quality measure. So it is super, super important that we truly assess how are they locomoting on that unit. And locomotion on the unit is in the room and in the corridor. That's two components. So if you have somebody on quarantine, just because they didn't locomote on the unit, if they did some locomotion in their room, that counts towards on the unit because it's both. So those are components of that. So you really want to make sure that you're capturing that and asking the staff, did you ever push them in the wheelchair? Did that happen a few times? Oh, let me just bring you down. Oh, let me bring you over here. Oh, let me push you into the bathroom. If that happens 3 times, at a minimum, that's an extensive assist if they're able to do some locomotion on their own. So like I said, it's very easy, a lot easier than you'd think to capture somebody as an extensive assist. And it's just so easy for this one to trigger, just so easy. So really make sure that you're getting it right on that earliest assessment. Dressing, don't forget those elastic stockings and prosthesis, that's part of it. I don't know how many folks can get the TEDs on with, just dangling their leg up in the air for you to cram those TEDs on. There's usually a degree of weight bearing associated with that. How the resident eats, drinks, meals, snacks, not stuff off the med cart or, crushing up the pills and giving them their pills that way, but snacks, meals, TPN, IV fluids, G-tube is part of that for MDS coding. A lot of times your CNAs may document not applicable or didn't happen, but how did they receive their nutrition? It's really not just eating, it's how they receive their nutrition. And then toilet use. Toilet use is broken down into 6 different components. Super, super easy to code somebody as an extensive assist for toilet use. If you're just looking at those components, you could have somebody who independently walks to the bathroom, does everything, but you have to wipe them each time. You're providing total care for the cleansing self after elimination. 3 times that happens, that person's an extensive assist. So really make sure that you understand this is one of those late loss ADLs, pretty easy to trigger those quality measures. Personal hygiene, another one that's broken down. Each one's reviewed as a separate component. This would be very rarely captured as a limited assist. Just be mindful of what it is you're looking at, what has really happened during that observation period. And really making sure that you and your team understand these definitions. Like I said, this is just kind of a brief scrubbing overview, wet your whistle, if you will. Maybe we can dive into it deeper in another one of the sessions in the future. But the self-reference, making sure that you understand what it is you're coding. Really read section G of that REI manual and understand those definitions. Did it occur? Did it total dependent, extensive assist? I like to teach it backwards. All of these different things We really need to make sure that we have a good understanding. Total dependence, they did absolutely nothing. That's an all or nothing code. They help one time for that ADL, they can't be totally dependent due to the exclusion due to the rule of threes. The extensive assist, we've got two definitions, as you can see here. Very easy for somebody to be extensive assist because it's such a huge range of ability within the extensive assist definitions. Limited assist, really small amount of assist, just a hands-on, you're touching, but you're not lifting, you're barely doing anything, but you are physically touching the resident. Handheld assist while ambulating, buttoning a blouse, hand over hand washing. And if this occurs 3 or more times. Supervision, you just have to oversee, give instruction, but you're not touching them. Unfortunately, with MDS rule of 3 and the algorithm on page G-8 of the RAI manual, even if they didn't meet the rules of 3, even if you didn't have supervision happen, they may end up being a supervision code. So it's just one of those weird things for section G that you really have to understand. Independent is an all or nothing. They'd have to be independent with that ADL every single time. And then our staff assist support that is needed. No staff, setup help only, which is just touching equipment. One person physically touching the resident. So you could have somebody who's supervising, but they're not a one person physical assist, because once you're a one person physical assist, you have to touch the resident. So a one person physical assist to complete those ADLs, or a 2+ person physical assist. And the rule of threes, if you don't understand it, I mean, in this quick overview, this is certainly not intended to be an instruction, but make sure that whoever's coding that section understands the rule of threes, is truly asking the questions, because a lot of times CNAs are documenting once a shift. It's not once a shift that we're looking at, it's episodes. How many times did they transfer on that shift? That's part of the calculation. So 3 episodes, you could, like I said, you could code your MDS off of one shift potentially. Just a reminder, any care that's provided by family, hospice staff, private duty aides, nursing, or CNA students that are not your employees. So like if they have an outside school coming and doing their clinical in your building, volunteers or ambulance attendants, any care that they do does not count towards coding on the MDS. So if you have any of those folks coding in your CNA documentation, it needs to be very clear to the MDS coordinator who did that documentation. And I don't recommend having them do any documentation because it doesn't count. So just keep that in mind. Maybe they can do some other type of documentation. I know that was like a whirlwind. I feel like complete whirlwind of G, but it's just so important to understand. You really have to understand this section. It's just so easy to mess up, to be honest. And, you know, it's very easy to trigger the quality measures for those different items. So we've got some notes in our chat about the evaluation link, and make sure that you fill that out so you get your CE credit. I have a minute or two for questions. If anybody has any questions, and certainly if things come up after, here's my contact information. You can reach out to Mountain Pacific Quality Health, and they know how to get a hold of me. If they have any questions, direct them towards them, and then they will direct it towards me, or you can contact me directly. So I hope that you found this presentation helpful, or at least started stirring up some questions and different things that you can do in your building to maybe improve the process with your flu and pneumonia vaccination documentation and capturing on the MDS, and then maybe starting to maybe stir the pot a little bit on that section G information.
Jennifer, that was great. Thank you very much. I don't know if anybody has questions. If you do, be sure you can send those my way, and I'll get those to Jennifer and back to you. And we thank you for your time today, for jumping on this webinar. We will offer the 3rd series in September, I think, Jennifer. Does that sound about right?
Yep.
Okay. So we're interested to know what your needs are as far as MDS training. So please think, if you think of things that would be helpful, send those our way and we'll get those in front of Jennifer and we'll try to focus our next training towards things that are relevant and important to you. So have a great rest of your day, folks. And thanks again, Jennifer.
Thank you. Take care, everybody.
Bye now.